Thrilled to introduce, oh, we're recording, got it. Great. I'm thrilled to introduce Dr. Michelle Marie Peña. She is a neonatology attending from the Children's Hospital of Philadelphia. When she's not taking care of her 7-month-old baby who's crawling with 2 teeth, she is also developing and leading tons of different projects focused on health equity. She is here to share more about this area of expertise. She has got a lot of projects that she is working on around disparities in breastfeeding and neonatal follow-up program engagement that she's going to share a little bit about. So our hope with this session is to really bring that framework to life, see how it's applied in real life. And many of us on this call are primarily focused on primary care and outpatient settings. And so this example, I think, will really lend itself well to those settings as it sort of bridges both inpatient and outpatient, but it's a very common thing. How do we get that follow-up appointment? So really excited to welcome Dr. Michelle Marie Peña, and I will turn it over to her. Thank you.
Thank you, Rebecca, for that wonderful introduction. And hello, everyone. It's really wonderful to meet you virtually through Zoom. As Rebecca said, my name is Dr. Michelle Marie Peña, and I'm a neonatologist at the Children's Hospital of Philadelphia, as well as the Hospital of the University of Pennsylvania. So I'll be sharing today my presentation entitled Equity Focused QI, Addressing Inequities in Neonatal Follow-Up Program Show Rates. So I have no relevant conflicts of interest to disclose. And the objectives for today are to first define equity-focused quality improvement, EFQI, as a framework to address disparities, to review concepts of the EFQI framework, many of which were reviewed in the recording that was previously shared. And then the bulk of the presentation will be applying these EFQI concepts to a case study.
I'm sorry to interrupt. I don't think your slides are sharing. Do you mind?
Yes.
Thank you.
Thank you. I won't do it again. I won't go through those slides again. But just for the objectives. I'll review EFQI as a framework, and then can you see my slides? Okay.
Yeah.
Okay. Perfect. All right. We're off to a great start. Okay. Then I'll review the concepts of the framework, and then apply these concepts to a case study, and that's going to be the bulk of the presentation today. So before I jump in, some things that I should share about me as I'm doing this work in health equity, and as I'm doing work that's helping communities of my own as well as other communities. I think it's important to reflect and think about what you bring into all that you do. So I am a Cuban American heterosexual female, and while some of the project today that I'll be describing is focused on disparities that parents who identify as Black or African American experience. I am not a member of that community, but my goal with this work is really to center and amplify the patient and community voice. And then, as Rebecca mentioned, I am a neonatologist, so that's I'm a pediatrician who specializes in the care of newborn babies. And so I understand that that is not the primary audience today, and you all take care of a very different population. And I do also work at a well-resourced academic hospital. But as Rebecca said, I do think that this case study hopefully will provide some examples or some nuggets or some experiences that you could potentially take home and apply to your work locally. And ideally, this would be work that and some ideas that could potentially meet you where you are. So to start, just a general overview of equity-focused quality improvements. So these are QI initiatives that integrate equity throughout the fabric of our project. So this is meant to be inclusive, collaborative, with patients, community members, and it's meant to prioritize and address the needs of groups that are experiencing a disparity or inequity. The key features to this framework are that it's action-oriented, it's centered around equity, and equity is centered throughout. It's not meant to be a post hoc analysis, and the goal is that you use these EFQI principles at every single stage of a QI initiative. And so we shared a lot of our best practices in this manuscript in seminars in fetal and neonatal medicine. entitled Using Rising Tides to Lift All Boats, Equity-Focused Quality Improvement as a Tool to Reduce Neonatal Health Disparities. And I'd like to spotlight my co-authors, Dr. Reichman, Braccio, Madhu, and Montoya Williams, who put this together as a team and collaboratively. And while it does specifically talk about neonatal health disparities, especially in the beginning of the project of the manuscript, towards the middle and at the end of the manuscript, there's certainly best practices and lessons learned that can be adapted to address disparities in patients of all ages. And so I think you may have had been given the paper previously, but it's also linked here with this QR code. And so then just to briefly recap the concepts that were reviewed in the pre-recorded session. So the first concept was talking about fostering a culture of equity. The second, to address the disparity, it must first be identified. So talking about the importance of stratified data based on a specific sociodemographic factor. The next concept is to incorporate equity into every stage of a QI initiative. The fourth, family and community partners are critical stakeholders. 5, considering alternative comparator groups that's specific to your case. And then 6, focus of the work should be on the evaluation of root causes and modification of systems and processes, so that the blame is not on individuals, but more thinking about the system. And then 7, adapting data visualization tools to emphasize disparity trends over time. And then lastly, to approach dissemination of data from an equity perspective. So just that's sort of meant to recap and bridge the pre-recording to what we'll be talking today. And so I'll jump in now to the case study. And as Rebecca mentioned, this is a case study of a QI initiative that we're working on addressing inequities in neonatal follow-up show rates. And this is a work in progress. And so we are still in the midst of designing our PDSA cycles, but did want to share a bit of our project design, the principles that have informed our project design. So just very brief background on neonatal follow-up program. I know this is probably different than the clinics that you're a part of, but just so you have some context. So this program is basically outpatient clinics that are designed for infants after they're discharged from the neonatal intensive care unit. And typically babies are referred to the neonatal follow-up program during the NICU stay. During their NICU stay, you'll have their appointment, and then they'll be seen at our program after discharge. And the reason for this clinic's existence is because NICU infants are at increased risk for developmental and growth challenges. And so this clinic is meant to support families, to perform developmental evaluations, and also ensure that the appropriate referrals have been made for specific support services like physical therapy, occupational therapy, and earlier interventions, depending on the specific patient experience. And so when we talk about neonatal follow-up program and neonatal follow-up program engagement, there have been many disparities documented in the literature. Here are just 3 of them, where several of these studies have highlighted the existence of disparities in show rates after discharge. And so it's definitely something that has been seen in the literature, in databases, in statewide collaboratives. And so as we were thinking about an equity-focused quality improvement initiative, we wanted to think of which disparity-sensitive measure could we use. And in thinking about how this has been studied in the literature, this would definitely, the show rate, so show rate to this neonatal follow-up program would be a measure with a known disparity. And then it would also be a measure of care decisions impacted by provider behavior and discretion. When we think about how it is that families have appointments made and are taught about this program, it's a communication sensitive process, and it also would be impacted by social determinants of health and getting families to attend clinic. And so as we were thinking about a project, and this seemed like a natural project to do work in and to investigate whether locally we had these disparities. And so when we did our initial just quick data pool, looking at our show rates by race ethnicity, as was seen in prior database studies, we did see that in our clinic, there were disparities. So you can see here, this is specifically no-show rate by race ethnicity. And then in blue, you can see non-Hispanic Black. In red, you can see Hispanic Latino, which is a small patient population in our clinic. And then in yellow, you can see non-Hispanic white. And you could see here specifically, most notably, you could see that there's a disparity over time between white patients and Black patients when you just look at a quick data pool at our show rates. And so this observed disparity, I mean, this was something that was not on our radar. It certainly wasn't how we were tracking our data longitudinally, and work had been previously done in trying to improve our show rates in general. But looking at the stratified data, we would not have known that there was a disparity unless we had stratified the data and stratified this chart. And so with this, we decided to look a bit closer and look at specifically our initial visit rate, our initial visit engagements. And so you can see here, this is just for the first time a baby comes to this clinic. And so you can see here in this chart, in yellow is this is our no-show rate. So in pink down here, you can see the show rate for white patients, and then in blue, you can see it for Black patients. And you could see here that the mean here was 37% for no-show rate, and then versus 17%. And so we decided that we wanted to further investigate where the root causes of this disparity. But before jumping into that, I did want to take a moment and think and have a conversation about why is it that we were looking at this data by race and what it means. So as we're doing this work, I think it's really important that you, like in talking with your teams and talking with your stakeholders, as well as your division, departments, those who are interfacing with your initiatives, is to make sure, especially as you're stratifying data, for example, by race, that we're sure to talk about it as a social construct and make sure that we talk about what it specifically is representing. And so as we're talking about race in this initiative, we are talking about it as a proxy for racism. And we also know that there is intersectionality with other factors, including social determinants of health. And so this is actually a paper that was just published. It was just released a lot in the last few days. And I think it's a great framework for really understanding and thinking through race and the intersectionality with other factors. So just even looking at the caption, talking about structural racism, and I read these words mainly because they're not my own, and I want to give credit to the authors, Dr. Hurd Garris, and their co-authors, but really thinking about it as a product of white supremacy and capitalism, defined as the differential access to societal goods, services, and opportunities by race. And then this is manifested in unequal access to power, resources, rights, and protections. And then that shapes the settings in which children live, learn, and play, and in turn shapes intergenerational health outcomes at the individual, family, and community level. And then together, structural racism, white supremacy, and capitalism create poverty and poor health and concentrate poverty and poor health among racial and ethnic minorities. And so I bring this up just as one conceptual model to talk about the intersectionality as we're thinking about race and other factors. As we're thinking about how we compare who or what groups we compare in this kind of work, it's also important to talk about and be intentional who it is that you're comparing. And to caution against using a default. Usually in most studies, you'll see that white is the default comparator group. And this is known as the white racial frame. And this is from another paper by Dr. Hardiman, where they talk about our methodologies also often replicate white supremacist framing by making whites the dominant group to which we compare all other population. And so instead, we challenge groups to think about these comparisons in a more case-by-case manner. So thinking about thinking about size. So do you want to compare the two largest size groups, and that's why you're choosing them? Do you want to choose a specific group as the comparator because of performance, for example, is another consideration. However it is that you choose the comparator, my suggestion would be to be intentional about it and then be explicit about your reasoning. Because with this, we want to make sure that we're not reinforcing racism. And so for this particular project, as we looked at our population in our visit volumes, you can see here in blue are patients who identify as non-Hispanic Black, white is in pink, and then other is in green. And I will say our other group, the data is very sparse, and it is definitely data where we have some patients who identify as Hispanic, some who don't, and it's a mixed bag. So we ultimately decided to go with the second larger group. And so for this project, we ended up using patients who identify as white as the comparator group. And so for this particular project, as we do for most projects, you'll be specific about your cohort. So we specifically looked at babies who were discharged from our 2 local NICUs, from Children's Hospital Philadelphia and the Hospital of the University of Pennsylvania. And then we defined our operational definition. So we talked about the initial visit no-show rate, and we specifically looked at the initial visit primarily because we wanted to understand the process and impact the process while inpatient in the NICU. And so we focused on the initial visit no-show rate and defined it as no-show, a patient who never showed to their appointment or that they canceled within 48 hours as a numerator, and then the denominator included the numerator plus completed visits. And so our initial SMART aim was to reduce neonatal follow-up program no-show rates for Black patients from 37% to 30% by June 2022. And so as we were first starting our project, we realized and did some more reading and more reflecting. And I will say this is really important as you're doing this kind of work, is to continually be learning and continually be improving yourself as you're doing your work. And one thing that we noticed would be important to do is to make sure that we reframed our question. And so this comes from that same paper I mentioned before by Dr. Hardman, is thinking about research, how you phrase research questions and what messaging that brings. And so, for example, the quote that I'm going to share here, research questions are often phrased as what causes Black people to have so many disadvantages compared to whites, and what forces are at work. This type of questions reinforces racism and white supremacy, suggesting a Black deficit and subtly reinforcing a narrative and a story that is privileged over other stories. And so I think I bring this up mainly to make sure that as we're having these conversations, to think about framing problems and framing issues in a more strength-based. And I think also inviting, I think the authors were also trying to encourage folks to also think about areas where marginalized groups and minoritized groups are also having successes and triumphs. And are there ways that we can also not only just look at these groups, minoritized groups, as groups that are having worse outcomes, but potentially also using a more strength-based model and potentially also looking at areas where the outcomes might be better. And so with that, we ended up reframing our project to be focused on show rates. And so you see here on the left, our run chart that we're currently using, and you could see here in blue are patients who identify as non-Hispanic Black, in white are patients who identify as white, and you can see the median is 62% or 63% versus 83% versus 87% in show rates. And so with that, our global aim is to explore the diversity of patient experiences and identify root causes of neonatal follow-up program show rate inequities. And specifically, our SMART aim was reframed to improve, sorry about that, that's a typo, to improve initial show rates of Black patients from 63% to 70% by June of 2022. So to do this work, we created the Neonatal Follow-Up Program Equity Working Group. And you can see here, the group includes NICU providers, so includes frontline providers, fellows. We also have a NICU nurse champion, and then we also have clinic providers and personnel, including clerks, administrators, and then we recently hired a new social worker and a new nurse coordinator. And then the goal with all of this work is to center it around the patient. And I'll get to a bit more about ways that we're incorporating and centering the patient voice in this work. So to start this work, we compiled, we worked together collaboratively and worked to understand how is it that patients are given an appointment, and how is it that we go from birth to appointment in our 2 NICUs. And here in this process map, you can see here, you actually probably can't see it because it's so many boxes, but what we learned as we put together our process map from birth to appointment is how many steps it takes to go from a patient in the hospital preparing for discharge after a complicated admission to then having a patient physically show to the clinic. And the big take homes that we had were that there are many steps and that many of them were not reliably occurring. And so it was a really great first step in thinking through how is it that we expect these appointments to be made and patients to arrive. And so it was critical for us as we were preparing and planning this project that we centered around the patient voice, and specifically this idea of centering the margin. So thinking about shifting a discourse's starting point from a majorities groups perspective, which is the usual approach, to that of a marginalized group or groups. And this is a quote from the paper from Ford et al. Below. And so to do this, there are several methods, and I'm sure you have all experienced as you're doing patient-focused work. You could use patient family council or patient advisory councils. In an ideal world, you can include patients into your stakeholder group, into your working group, and then additional methodologies like qualitative methods to ask patients, to informally ask them questions, get feedback, to collect surveys, for example, or other ways. Other tips are to make sure that your team is also diverse. So who is in your stakeholder group? Do you have different perspectives included? Do you have, is there, for example, folks who are interested in health equity work in your division or in your group, in your clinic, in your practice group? So are there folks that you can incorporate from different backgrounds that have similar backgrounds from your patients? So this is one other way to consider thinking about your team. I think the more diverse your team is, the more perspectives that you'll also include. It doesn't take place of patients, but I do think it's really helpful to have people from different disciplines and different backgrounds be a part of the team. And then ultimately, as you're learning from patients, especially as you're trying to learn from specific patients. So for example, in this group, we wanted to learn from patients who identify as Black or African American. Our goal isn't to say, well, this group of people think this, or this group of patients want this. It's not to generalize, because we don't certainly want to contribute to stereotypes or contribute to creating generalizations, but more than anything, to learn about the diversity of lived experiences and center the different things that we learn from patients. And ultimately, we would be able to illuminate and address the root causes that we learn from patients. So to do this work, we ended up doing phone interviews, and this was added to a process that already existed. So if a patient hadn't shown to an appointment, typically one of the people from the front desk would then call the family and work to reschedule the appointments. And so we added on to this process, and we specifically asked families in a sensitive way. We asked them if it would be okay to ask them a few questions, acknowledging that it's often really hard for families to get to appointments, especially with kids. And so if the family agreed to answering these 3 questions, we proceeded. And so one question we asked was, what made it difficult to make it to today's appointment? Did you know what this appointment was for? And we also added that several families often have many appointments and may not know what each specific appointment is for. And then we followed it with this specific probing question. And then we asked families to give their ideas about what would have made it easier for them to be able to make it to the appointment. So we used this as well as our collaborative team to create our key driver diagram. And so here you can see key drivers like medical team knowledge of eligibility, parents' understanding of this program, scheduling appointment prior to discharge for eligible babies, communicating this appointment with families, remembering the appointment date and time, their pediatrician understanding the purpose of this clinic, and getting to the appointment, and then variation in the process between hospitals. And you'll see here, there's some that are shaded in orange, and this is just one way to frame this driver diagram, where in orange, we included potential drivers of disparities in care, specifically racism and bias in care. And so we went through like the typical process of creating a driver diagram, but we specifically tried to brainstorm like, where is it that we can find racism and bias in care? And I think that's a critical piece in thinking about specifically and calling out specifically, where is it that we could see racism and bias in our care? We then brainstormed our secondary drivers and then our change ideas. And we have a few ongoing, which I'll get to shortly. And then we have These are current family of measures, which is in progress as we are working on our countermeasures. But you can see our outcome measure is our initial visit show rate by race and by NICU. And then our process measure is having an appointment made prior to discharge. As far as the qualitative data, I mentioned that we had called families to learn from them and get feedback from them. We actually were able to successfully reach 10 out of 14 families who had not been able to come to their appointments and to learn about barriers. I think one key piece of information that we learned was that 60% of families did not seem to understand the purpose of the appointment. And so you can imagine if families don't understand why they're coming to the appointment, that may affect potentially their motivation to be able to come to the appointment. And then when we talked about specific barriers, the most common barrier that parents shared was transportation. The next most frequent one was parents forgot. Then challenges with childcare, the timing of the appointment was challenging, and then one other categorized as other. And we use this Pareto chart to show the most frequent to least frequent barrier and themes that we learned. And then we use an impact effort matrix to prioritize our change ideas. And I will share a little bit more about how we pick, but I think main ideas that we're working on right now are working on connecting families with the neonatal follow-up program during their NICU stay in a more reliable way. We're also working on providing nursing education and making sure that families or that our providers understand the criteria for eligibility. But I think the most important thing that we're doing right now is streamlining the appointment making process. And so we've incorporated it into processes of care. So for example, we already have a discharge checklist. And so we've added this, the task of making sure that a family that a baby that is eligible has an appointment. We've added that to our discharge checklist. We've included it into our holistic rounds. Like I mentioned, added it to our frontline provider. Like there's a resident card that includes all of the criteria for this follow-up clinic and other criteria for other care decisions and care support. And so we've updated that. And then, like I mentioned, education is a big intervention. So in families, making sure we're including this in a standard way in our discharge education, that nurses who are performing this education also are educated about this clinic. We've incorporated in resident lecture, and as well as for fellows have received education. And then we have some reminder calls going as well. And so we've overall called this first 2 points sort of our discharge bundle. And then in the last few weeks added on reminder calls. I think in the future, we've been working hard and thinking about how do we engage patients in this work group, because it would be really wonderful to have patients actively in the group, especially as we're thinking about prioritizing, and especially as we move towards a phase where we do more education inpatient, which I imagine that we'll get to. We also need more input in thinking about how do we streamline and standardize our call reminders and no-show process. And then one other piece that we're trying to learn more from is our research studies, for example, have really great show rates. So is there something we can learn from our research protocols and what outreach they perform? And then thinking about how else we streamline our process. As we've been doing this work, I think we've also been looking at the literature and what other places have been doing, and even thinking about general, for example, for us, like our neonatal follow-up, in generally improving neonatal follow-up program, and what lessons learned can we take from others' work, and how can we tailor this to our population. So my goal is eventually to be able to put together what you see here, which is a value stream map. This is a tool from Lean Six Sigma, which I'm sure many of you have seen. And what I love about this is that in addition to mapping the actual process, it's also showing the flow of people and time. And then it's showing also all of the problem areas in the burst symbols. And then you could see here the barriers and additional solutions that this group has done, and they've shown improvement in their work in Colombia. This is by Dr. Breccio. And then also, as we're thinking about change ideas, other ideas to think about, and I think this may apply more to your adult population. What other things have been tried when thinking about missed appointments? So this is a study done by Dr. Chaichadi, who's here at Penn, who had looked at rideshare-based transportation services and seeing if that would help with missed primary care appointments. And interestingly enough, in this randomized trial, pragmatic trial, they didn't show any difference in patients that were randomized into being provided a rideshare mode of transportation. And interestingly enough, they subsequently did a qualitative analysis. So this is the lead study. The lead author was Brown. Dr. Chaichadi was the senior author for the study. I think there's much to learn from even how they ended up designing their qualitative study, where they ultimately wondered if, while transportation, for example, is a commonly cited barrier to attending visits, their randomized trial ultimately didn't find that providing this rideshare transportation ultimately improved their show rates. So it made them wonder, is there more to trying to understand, for example, transportation? So is it more, is it the cost? Is it the, ability to get transportation? Is it the flexibility? And so I put this here mainly because as we think about, for example, if transportation becomes a target, I think one thing that they ended up asking about in their interview guide is more targeted question about transportation. And so, for example, you can see here, how does the availability of transportation impact your choice, whether you attend or miss your clinic appointment? If transportation has an impact, what do you care about most when choosing your ride? Examples include reliability, cost, etc. Does the distance from your home to the clinic play a role? And so I share this here as an example, as you're thinking about, for example, if you have a project or initiative similar to this one, here's an interview guide that you could potentially even start from and learn from, and potentially adapt to your community and adapt to your clinic. And then they ended up, these are just some of the themes that they shared. But for lack of time, I'll just move on. And I think overall lessons learned from this work, I think one is the role of stratified data. Like I said, if we hadn't stratified our data, we wouldn't have even known that there was a disparity. The importance of considering comparator groups on a case-by-case basis and being explicit for how and why you choose the groups to compare. The fact that discussions about racism are challenging but necessary, and even the first step of calling out racism in our hospital system, I think is a really important first step in doing this work. Language matters. So if when we're talking about social determinants of health, when we're talking about race, what are these a proxy for? And then thinking about the patient voice and lived experience and how critical it is to make this central in this work. How helpful research is and looking up prior groups' work to help ground and inform your work. And then ultimately, this work takes time to do it thoughtfully and in a community and patient engaged way. So I'd like to acknowledge our neonatal follow-up team, the patients that we see there and their families, our neonatal follow-up equity QI team, our QI team over at CHOP, and then our NICU at both of our hospitals. And I'd like to stop there and welcome any questions.
Thank you so much. That was fantastic. After getting the chance to read your article and also watch your video, it's really wonderful to see it applied to not only a real life scenario, but an in-progress one too. So excited to see where it will go next. We'll open it up for Q&A from everyone. If you have a question, you can just say, I have a question, and I'll call on you. You're also welcome to type it in. As what we like to do in CIN is I'll call on you essentially, and then you can ask your question directly so that we can have a bit more of a dialogue. So Tar, we'll start with you. Would you like to unmute yourself and ask your question? or it might be more of a comment, but go ahead.
Yeah, yeah. I feel like my question was already kind of answered around transportation because we hear the exact same thing in across, public health and where when we discuss anything with our members that transportation is always a huge barrier. So here, in California, transportation is a covered benefit. So we've tried ride sharing, we've tried bus passes, same day bus passes. Um, and yeah, we're not sure, I think, if it's working. And if there is a preferred method, we would love to know, right? So it's nice to see that someone's looking into it, and maybe we'll find out if there is a better way to do transportation for our members, because I think regardless of the program, it's going to be listed as a barrier, especially our area is mixed urban remote. So we have very far reaching, very, like farm country kind of members don't even have access to a bus line. So what do we do for those members, and is it worth their time? So
No,
not really
absolutely.
question, comment. Yeah.
No, and thank you so much for sharing. In Dr. Chatty's work, he did mention how there is a Medicaid benefit that some families rely on to come, and this is from an adult primary care standpoint. But he did write in his paper that it has historically been unreliable, for example. And so I think one of the teaching points that I took away from his paper was, even if you have these benefits and it seems like a logical, like, okay, transportation is an issue, here are modes of transportation, I do think that it's critical to ask patients, did they know they had those benefits? Was it hard to access? Was it reliable? And I think that was one of the takeaways that I had from their patients from that analysis, and even thinking about the randomized controlled trial that showed negative results, is really, even if we have a system that we think works, like, who's designing that system, and is there a way that we could design it for the specific barriers, and are there more nuanced questions that we can ask patients to better get at what is it that is causing a challenge to access this service and access to a more reliable way to get to clinic, and is that ultimately the challenge? I that's where I think the patient voice is critical in trying to tease out the exact challenges.
Thank you. Next up will be Christine Castano, who's related to transportation, but sort of getting at solutions there. So Christine, I'll turn it over to you.
Hi, thank you. I really enjoyed the talk, and in particular, that perspective, instead of looking at why does this group do worse, is saying, what can we learn to improve this group? And I really think that that's a really cool way to look at it. So kind of on the same lines, given that transportation was such a factor, I think we talk about structural racism in terms of, society and economic models, but I think we also need to look at ourselves as medical providers, and we have a very medical provider centric model. So why do they have to come to us in the first place? So have you looked at what aspects of your follow-up program can be delivered in ways that don't make them have to go anywhere? So virtual, or people going to them instead? I was curious about that.
So that's a great question. I think for our particular population with newborns, during the pandemic, they did adapt to doing virtual visits, and I did chat with the medical director. So I started this project as a fellow in neonatology, where I had some exposure to the clinic, and since then I've been more supporting in this role with this project. But when I asked her, do you think that this could be an intervention we could try? Can we try transitioning to virtual? But I think for this particular clinic, where it's part of the work that they do is physical therapy assessments, developmental assessments. While they could get, something is better than nothing, of course, where, virtual would be probably better than a no-show. It is still a program where they do want the babies to come in and the families to come in person. But I do think it's a very valid point, and I do think that it's something to consider in whatever setting it is that you're practicing. Are there ways to make it easy, make it easier for patients to meet you, and for you to meet them, as you were saying? I think that was beautifully put. And so I do think that certainly could be an intervention, and I do think that more and more clinics are finding ways to incorporate virtual visits into their models. And I think that that certainly should be a consideration. And see for your patient population, does it make it easier? I think that's another piece to make sure that to ask the patients, is that something that would be easier for them?
Great, thank you. Sunita, you're up next.
Hi, Michelle Marie. Thank you so much. It was it was fun to hear it, and now I want to know what the outcome is going to be. So you'll have to give us an update. I had 2 questions for you. I'm going to ask you the one that's probably the most important for me. Tell us a little bit about how you engage families in thinking about measures, because I think one of our challenges in measures in general is we have so many, they're so systems driven, that I'm curious to hear how you've thought about it and what creative ideas you have about how families can help us think about what the right measures could or should be.
So thank you so much for asking. I think that that's such an important and helpful question. I think as far as this project goes, so the main ways that families have been integrated has been with our qualitative analysis, where we have mainly just asked families, like, what has it been like to try to get to this clinic? I do think we can broaden that to not only families who no showed, but also learn from families who showed, like, what was it like getting here? What helped you get here? What made it hard to get here? And then I think, like you mentioned, like, how do we incorporate families to help us in doing this work, identify measures, like you mentioned? I think that's the next step in our work. And that's the part where I'm still learning and trying to figure out how it is that we do that in a way where families feel welcomed, respected, and valued in this work. I do think our next step is going to be, as we design how it is that we provide education inpatient to families about our clinic, for example, that we need to have families help us to co-design that. And so incorporating what it is that they think would be helpful to learn about, what it is that they wish they would have learned, what practically would be helpful, I think would be really important. And I do think when we're talking with families and trying to ask their input in identifying measures, I think using open-ended questions to get their input, but then also asking for specific feedback on specific questions, I think is probably a way to approach this challenge of, like you mentioned, like we have so, like, in medicine, we're just constantly like on information overload. And so really thinking about, like, how can we be very targeted in making sure that we provide families with a specific question, ask for specific feedback in a way that is understandable, I think takes work. And I think that potentially even thinking about community partners might be someone that could help potentially bridge that divide between, hospital work or clinic work and patients. But it is a challenge, and it's certainly something that I'm still learning. And so this stream of consciousness that I just shared was sort of how we've been thinking through and trying to think about different avenues as we start thinking about having patients join our working group.
Thank you. Great. And next up is Christine.
Thank you for your presentation. Really awesome work. My question is really around the collection of the data that lets us stratify across race and ethnicity. Mm-hmm. So, we all probably struggle with this, our populations. And my background is really working with healthcare technology, particularly EHR systems, to try and be able to query this type of data. We find that it can be unreliable, it's not collected in standard fields, or a patient does not feel comfortable reporting that data, which also is indicative, right, of issues. And so what did you guys sort of do to either get around that or to validate that the data you were collecting was correct? What are some tips that you might have around that?
So that's a great question. I will say our hospital system as a whole has worked on trying to ensure that these data are self-reported. And so it is sort of part of, like, when you make an appointment and as a new patient, it's part of the questions that people are asked on the phone, for example. And it's certainly something that like I mentioned, the key is that it's self-reported. I don't know the answer as far as accuracy for our specific health system. I will say it's very rare that we have empty fields, and we know, like I said, like it's sort of streamlined into our process. One of our other adult hospital has worked really hard to also expand the categories and the flexibility in being able to provide multiple answers and also more specific answers. And I know that a lot of that work, for example, was from like a top down, where leadership really wanted to work on streamlining the process and improving the accuracy. But I will say the focus has been on ensuring that it's self-reported. But I think your question about accuracy is really important. And I do think even like similar to that point is making sure at wherever it is that you're practicing or you're caring for patients is really understanding the process of collecting this data, because there are certain, I do think that sometimes it's challenging. For example, like if you don't know how these data are being collected, is it somebody that's assuming things and just checking them off? And that's the hope that is not happening. But I wish I had more specifics. But I do know that our hospital as a whole has been doing work in this equity focused QI space for a few years now. And one of the first steps in doing that was to, like I said, like streamline who is asking patients about this information, how is it asked, and then also making sure that it's self-reported.
Thank you. Just really quickly, are both of these hospitals on the same EHR, or are you on different EHRs?
They're in different EHRs, but when patients go to this clinic, it's through one of the hospitals, if that makes sense. No problem.
Great question. And it's such a challenge. And I'm hoping too that Ron Wyatt, our next presenter, can also give us ideas about when we're trying to do some of this work, but don't necessarily have all the data at our fingertips that we might like. Great. So next question will be from Sophie.
Also want to comment that the more we use the data, the better the data gets. We have seen that on race and ethnicity in California, I think, over the last couple of years. So that's encouraging. I loved Sunita's question around engaging patients with in how to define measures. So I have two questions. One is also how you decided to do the work on follow-up for NICU visits. You shared some evidence around disparities, but what's the role of listening to the community on how they experience inequities, and then prioritize, because given how much work it goes into these kind of studies, how did you decide to do what you did? So that's one. And then the other one is more specific around preferred language other than English. Do you capture that, and how do you experience that? And the reason I bring that up, we've seen huge variation in that data between in-person and virtual care. And I don't know why, but it seems to be a huge variation in being able to use that data.
Oh, thank you for asking those questions. I think from why did we end up doing this work? I do think working in the clinic, I think in general, and that's why there have been so many studies, in general, the show rates in neonatal follow-up program can be quite poor. And I think from our standpoint, in our looking at our patient demographics, we primarily serve patients in the West Philadelphia and Greater Philadelphia area in one of our hospitals. And then our other hospital is a tertiary care center. So we have patients from all over. And I will say it was very visible as you were in clinic, which patients were able to make it to appointments and which patients weren't. And so it very much felt like a local problem that was very evident, and so it felt like one that was really worth and important in thinking through and trying to better understand and work on. So that's for the first question. And then the second question about preferred language. So we certainly, so that group is a bit smaller. There are patients whose preferred language is not English in our patient panel. It is a bit smaller, but it's certainly something that in our future we're thinking about as we're doing our QI initiatives to stratify by preferred language. And the hospital has also done some recent work. Like for example, our EPIC now has a new field that's like right on the left side and very visible, where preferred language is entered for all patients. And so that is certainly a variable or sociodemographic variable that can be used to stratify your data. And so I do think that that may be an area to explore in the future. It is a bit of the smaller population. So right now we're focusing on this other way of stratifying the data, mainly because this is a larger group of our patients, but it's certainly not excluding patients who don't speak English. And that's certainly, I think, a really important group that we're including and thinking about as we're doing this work. I don't know if that answers your question.
Thank you. All right, next question is from Michelle Wong.
Hi, thank you so much. I just wanted to appreciate the presentation. It's fantastic, and there's so many pearls that I'll take back with me. I wanted to just appreciate your comment, and just one sort of key takeaway is about this work taking time, and also the emphasis you made around the resources required up front to do important work such as redefining questions, dividing the right comparison groups, involving patients. And so I guess my question is really a leadership question. What have you found effective strategies or ways that you can work with senior leaders or funders to really allow that time, build in that resource at the beginning, but also I would say also allow time to see outcomes on the other side. So just any tips you have around that would be really appreciated.
Absolutely. So that's still a work in progress. I will say, I think one of the most helpful pieces to doing this work is that my division chief, for example, and my hospital as a whole has made equity a very important strategic priority. And I in addition, like, so it's sort of like it's a time where this work is being prioritized, which is a wonderful thing that we can finally move the needle in a lot of this work, because these are not new disparities. These are disparities that have existed for a long time. And so, but I think right now we're at a place where, or at a time when places are putting priority in this. And I do think that it is a time where, like, for example, we have a different project on breastfeeding where if there's certain resources that you need to be able to complete work, where I do think in asking leaders and funders, there A is more available, and then B, I think more openness to fund it, in the sense that this is a time where leaders can put sort of their money where their mouth is. Like, if you're saying equity is a priority, I do think now is a time, for, my division chief, we had, for our breastfeeding project, we wanted to work with this community partner, and they were going to help us redesign our communication approach for patients and help make it more trauma informed. And so to work with this partner, we wanted to make sure we were compensating them as consultants. And we ultimately asked our division chief, and to our surprise, he said yes. And I don't know why we were surprised. We were like nervous to ask, but I do think even asking when we had a specific ask, we could show its value, and then also really emphasize that this is working towards equity. I do think that was that was a really big learning point for me, to sort of leverage now that folks are talking so much about equity. This work is actionable. This is concrete work that we could be doing to really move the needle. I do also think that there's much more like grants, local grants and national grants that are also out there, depending on what your work is, to do qualitative work, to form community partnerships. And so I also think that there are other funders to approach and to potentially apply for. And then the time and resources, I wish at the time piece, I wish I had an answer for that. I do this as part of my academic work, and we have a QI group at the hospital that also provides some support. But I do think that time is a resource, and time is something that should be given to this work and is needed, like I mentioned. I wish I had the perfect answer for you, but if you all have additional ideas too, I'm certainly learning as I go, and gaining experience, and my hope is to show value in this work, and that ultimately, I think if we can show value and we can show improvement, then then we can get more investment. But the hard part is you need investment to show value and to show the work. And so it's sort of getting this challenging space. But my hope is with what we have, trying to do our best with what we can.
Great, thank you. We'll go to Nicole next, and then Laura. And if we have time, we'll get to you, Samira. But we may have to stop. Nicole, would you like to answer your question? Ask your question?
Great. Thank you so much for spending time with us, helping us learn today. I was really interested in one of your slides. I kind of glanced at it briefly, and there was a list of kind of like primary factors and secondary factors. I'm not sure if it was called factors on the slide. And one of the areas that was in the secondary category had to do with their experience while they were in the hospital. I was wondering if any of that was looked at. I'm not saying it was the case that they didn't have an ideal experience while they were there, but I think sometimes it might be easy to say you didn't remember the appointment or there was transportation. Patients may not want to say anything about experience. So I was wondering if you looked at that directly.
No, that's a really great point. No, we haven't looked specifically or asked, what role their hospital experience may or may not have played in, their engagement with the clinic. But I do think that's a really great idea in trying to explore and get more into the root causes. And I do think it's also important as we're thinking about in-hospital interventions to get that feedback from patients, so that can inform how we approach the in-hospital work. But I think that's a really great point, and I think something that we can do moving forward.
Great, thank you.
Great, Laura.
Great. Again, thank you so much for spending time with us and for sharing your work. You mentioned, I think in your 8 points, one of the points was returning the data to the community. And I'm wondering how that's gone. What kind of forums are you thinking of using for that? And what has the feedback been? I think so often community is completely left out. I think we're beginning to ask them what their experience is, but actually returning the data is yet another step. So I'd love to hear your experience there.
That's a great point. So we haven't, so this project is still on the early stages. So we haven't gotten to the point to be sharing the explicit data. I will say we did share, especially as we were doing the phone calls with families, we did share about how this is, an issue that we find patients are having, which is, challenges getting into clinic. But I do think that I think as we engage families further, I'd like for families to be a part of how it is that we share this information back with the community. And so I don't have any concrete experience to share with you right now, specifically for this project. But I do think as we're thinking forward and we're involving families more actively in our stakeholder group, that is definitely one of the key questions we'll have for them, which is how can we ask patients for help and feedback, but then also how is it that we can share what we're learning and what we're seeing in our clinic.
Great. We're going to squeeze in Samira, if that's all right. One more.
Thank you. I'll be quick. I think a lot of the data can really showcase policy barriers that result in the limitations of access to care. And so I'm curious how you can use the data to influence policy change at these different levels.
Absolutely. I do think, for example, one challenge that we had is we didn't have like a nurse coordinator for our clinic. And I do think that potentially going forward, thinking about our care models and thinking about what parts are important for our families, potentially having this nurse coordinator or this social worker that we also didn't have, but having a dedicated person to help families navigate inpatient to outpatient, is that something that policy, like government funding or other funders can support in thinking about how it is that we help families transition from in the hospital to out of the hospital, I think is one place. I think transportation was thought to be potentially something that potentially policy can help with. And I know that, a lot of insurances may help with that, but I'm not sure that may be our solution. And so I do think thinking about, are there supports that we can provide families in the hospital to transition outside of the hospital? Are there also ways to create more meaningful interactions with patient advisory boards, or to create these patient groups and engage families in thinking about solutions that then can be evaluated and funded at larger or more scaled levels, I think is another future direction.
Awesome. Thank you. Thank you so much. Well, I hope you'll all help me in thanking Dr. Peña. It's always a little hard to do the full rounds of applause, but that was incredible. Really appreciated, just seeing how you're really applying the work. So thank you again. We are going to take a short break, 10 minutes. We're going to start right at 2.